Hello, can you all hear? What a bizarre experience. Well, welcome. We're having a session that's talking about supporting the sustainability of the NHS, and particularly from our point of view, thinking about the sustainability of EPR implementations. We'll let Jackie and Jane introduce themselves in a minute, but just as a brief introduction to us as the sponsor, we're Altera. We're a leading provider of electronic patient record systems in the UK. You can see there that across the globe there's 2,700 hospitals that use our software, and in the UK we support care of about 8 million people, patients across England, and that there are logins by clinicians, 2 million different logins by clinicians across England each week. The standard approach that many suppliers take to EPR implementations requires an enormous amount of change, often changing your paths as well as all of your clinical processes all at once, causing an enormous impact on some really stretched clinical and admin resources in hospitals. And really what we're going to have a conversation about today is that how we make that process more sustainable. How do we get to a point where you don't have to cause that level of impact and that much change on an organisation? So we're going to start by Jane is going to introduce herself and her organisation, and then Jackie, and then we're just going to have a chat about how it is that using the Altera product in these two organisations has worked for them and what we might be able to learn from that.
You can hear me now. Sorry, they've got to change over. This again is a really surreal experience for me. So hello everybody, I'm from the South East Coast, down in Kent, Maidstone and Tunbridge Wells hospitals. We were extremely challenged about 10 years ago, but we've completely turned that round, and we're one of the best performing organisations in terms of ED performance and cancer waits and 18 weeks. We've got no patients waiting over 52 weeks. We actually went live with our EPR during COVID. We've now been live for 2.5 years. And I do think a combination of that plus our patient flow system that we have is one of the major achievements around why we're doing so well today. So I'll come on to sort of the things that we've done and how it's not always been perfect later on in this kind of discussion. So I'll hand over to Jackie.
Thank you very much.
Do I?
Okay, thanks very much. Can you hear me now?
Yeah.
I'm Jackie Edwards. I'm Chief Clinical Digital Engagement Officer, which has been a new role that the Trust has introduced over the last 6 months. And that's partly because of our journey of the EPR that we've taken and the real focus that we've put on the importance of clinical engagement. I mean, unlike Jane, and I hope I'm sitting in your space actually in a few years' time, is we are a very challenged organisation. And I think we're similar in size to Maidstone and Tunbridge Wells. We've taken a slightly different roadmap that Jane has taken, in that our EPR was our very first encounter of that digital transformational journey that we took, and it was delayed a number of times. And I think that was one of the both opportunities as well as drawbacks that we had. An opportunity in that it really did give us time to get that frontline clinical understanding and engagement right before we started, so that everybody was sort of on the same page with understanding what it would look like, what we needed to be doing. But as you will see as we go through, it hasn't always been that easy, particularly with the clinical engagement. And some of that is similar to what we've heard this morning, because actually in the current culture and climate that we're living in, actually you don't know what's coming down the road at the moment. And actually, whilst your roadmap is as it is, actually it needs to change because our clinicians have to focus on very different bits. I think the bit that I'd like to come back to at the end is the importance that our digital transformation and our EPR has had in coming back to that, taking our clinicians back to that.
Right, thank you. It's great to have you both here. Thank you for your involvement in this session. I'm Mark Hutchinson. I'm here kind of with my Altera hat on today, but we over the last few years have implemented the Altera product at Gloucester, where I was the CIO for 5 years, and we'll perhaps also reflect on some of the things that we, between us, learned across all three of those organisations. We're going to start, Jackie, with you, if that's all right, to just talk about what do you think's worked particularly well over the period of your Altera EPR implementation?
Yeah, thank you. I think first and foremost I would say is about having clinical leadership. And when I say that, that's both at board level in our Chief Information Officer absolutely telling the story at board, so keeping our executive members, and at that time I was the Chief Nursing Officer, so actually hearing that and understanding how I take that message out to the professional group that I was leading at the time was really important. But actually really vital was actually ward clinical leadership. And identifying it very early on, who were those leaders that were going to actually really get behind it to start selling the story from peer to peer. And we had started our ward accreditation program, so actually we knew some of those wards that were actually really leading the way with their quality performance indicators, who were very much engaging with staff at that point in time. So we identified our pilot areas. And I'll never forget that one ward manager who came to me at the time, and it was an elective surgical ward, where I actually said, please can you come up front and be one of our pioneers in piloting it. And she said, why are you choosing me? I'm probably the most digital illiterate person there is. And I said, but that's not the reason I'm choosing you. I'm choosing you because of your leadership of your team. And I think that was an important message, and in fact they did extremely well in kicking that off. So actually I think it is absolutely pivotal. It is getting that engagement. The second area that worked very well was one of our frailty wards, where I knew that the multidisciplinary team approach was very strong. So actually that really helped in those sort of handovers, the ward rounds, the way EPR was being used for the very first time, to actually be able to actually see how it was working well. But also they gave us really good feedback on where it wasn't working so well, or where they didn't understand it.
Excellent, thank you. And Jane, from your point of view, what worked well at Maidstone?
So again, just reiterating Jackie's point, clinical engagement is absolutely key, but it's also following it up with what I would say is quick wins, actually promising to do something and then delivering it in a quite short time scale. Because if you don't do that, they start to lose the trust within the system. And I think one of the beauties that we've had with our particular EPR is it's quite bespoke, so you can actually make it do things that fit that particular organisation. So that way that clinician wants to work, you can look at developing that documentation to meet that, rather than asking them to actually conform to a way of working which they might not appreciate. And I think that has really enabled us to engage with our clinicians. But I think rolling out in phases as well has also made it quite bite-sized chunks. So you're not actually impacting on the whole organisation in one go. And so therefore you have effectively your pilot site started for us in ED, but we were then able to gradually roll that out. So we gained the confidence of your ED consultants, who are quite powerful within our organisation, and actually were then able to help their medical consultants embrace it when it came onto their ward areas. And then finally now we're going into surgery. They've seen kind of all of their other colleagues, so the kind of challenges that you might have got in a much more big bang kind of approach may have been much more harder to deal with. And it's enabled us to optimise and continuously change the way that we work to meet what they're dealing with. So with COVID, we've been able to adapt all the time throughout. And we've been able to come up with very innovative solutions. We're first of type for a new clinical decision support tool, which is around iRefer. And that's meant for our junior doctors. It's really helped them to stop having to order inappropriate tests. And so our patients are now getting through the system much quicker and getting their right test at the right time. So it's enabled us to do things like that, which has really encouraged our clinicians to take it on board.
Great, that's really good. And I think for me, if somebody asked this question for Gloucester, I think what Gloucester found really useful was being able to sit down with the 58 most senior nurses and matrons and chief nurse across the organisation and say, here's the blueprint, here's the best of the nursing documentation that Altera has. Do you want to take this, or do you want to start again and build your own, or shall we take this and slightly tailor it? And there was a really strong sense of support from the nursing community that if that works in a similar sized hospital in the UK, then we just want to make a few changes. And that allowed us to go live in 5 months, and as you described, that doesn't give people time to get weary or lose momentum. It meant that we could really promise that they're about to get a system, and 5 months later we were live on the wards. And I think that was a really powerful message to the rest of the organisation, that as we approach this in phases, we're going to be moving really quickly, and we're going to be able to provide something for your area really soon. So, Jane, what would you do differently?
What would I do differently? I definitely would never do an EPR rollout during COVID because if I had to go back. But we did, but that meant actually I learned quite a lot from that about being flexible in your approach. But also when you kind of go into your EPR, initially you're signing up to a contract for a particular length of time with key milestones that you need to achieve. And one of the things I would love to do if I could go back was actually capture the benefits throughout. We weren't always as good as I would have liked to have been, because you're on that treadmill of trying to make sure that you're getting your EPR rolled out in a way that you need to against your digital roadmap. So now it's quite hard to sometimes go back. You know you've made a difference, and people tell you as soon as the system isn't available for planned downtime, for example, how much of an impact that is to them now not to have their electronic system. But I can't put my finger on exactly what that benefit was. And also going live with your patient flow at the same time, you don't know whether it is your EPR or a combination of both. So I would really say, if you're embarking on your EPR journey, is make sure you get one of your team, their role is just to capture benefits, both before and after, so that you can demonstrate to all of your clinicians, your managers, your finance directors, exactly what that benefit is bringing to this organisation.
I'd have to echo that actually, and we're really experiencing that at the moment, because it feels a little bit like we're on catch-up, because part of that is then how you can celebrate the successes, and I'm not sure we've celebrated our successes with our clinical teams in the way that would really still keep them engaged, because that's one of the biggest challenges, certainly. As I said at the start, as you know, we're entering winter and we're entering a different phase of our rollouts, how do you keep people still with you when actually they're very distracted? But actually taking them back to saying that this is the fundamental element that will help you actually through that phase, because they just can't see it. People go back to what is familiar and comforting. And certainly I've gone on to some of the wards who have just said, oh, I'm just too busy today, I can't do that, I want to go back to paper. And our staff really have been challenged with, we've got a mixed model, so it isn't all electronic patient record. Some of the wards, because of the phased rollout, particularly the nursing documentation, hasn't come online. And one of the things that actually has really helped is getting peer-to-peer advice. So what one ward is doing and how they've said, you know, on the computers that they use, actually there's a list just by the side of what nursing documentation is and what isn't, because actually when they're really busy it's very hard. It's creating a network among the peers that I've found was really helpful to share that information. The other key bit that certainly I know my digital team members would say, please tell people this, is managing expectations. Because I'm not sure we put enough effort into explaining, actually, whilst it looks like this and this is your educational program to get you to use it, actually there is so much more that goes on behind it. So if I give you an example of our shared care record that we've brought online, we're still trying to engage with people because they don't really know it's there because they're just too busy. So our team that we had that wore orange T-shirts that they called the Orange Team were invaluable to us, of going round and just accompanying a clinician on a ward round and saying, have you seen this button? because actually, whilst you may have been taught it or you're familiar with it from the teaching package, actually they're not using it. And they're not using it because they're just too busy to click into it. So I think investing a lot more time in teaching and education would be the other big element, because then that helps you manage their expectations. Our team were inundated with requests of, can I have this changed? Can I have that changed? Because actually it was there already, but it's letting them know that.
Yeah, understanding what's there and how it works. And how many people have been engaged in that initial design is obviously really important. From a Gloucester point of view, it was, I think we had the lowest ever score of digital maturity when I got there. I think we had HIMSS level 0.18 or something slightly mad that came out of the system. And that meant that we were trying to address a lot of things in parallel, so it would have been great to be able to do order comms sooner, but we needed a new pathology system first. It would have been great to do electronic prescribing sooner, but we needed a pharmacy stock control system first. So it was great having the flexibility, as you say, of being able to implement the Altera product in a modular way, because it meant we could fit around all those things. And it was great that we got from that level of digital maturity to HIMSS level 5 in less than 2 years. It just would have been easier if there'd been a different starting point. The last question before we ask people for if they've got any questions for us was, what do you think the future looks like? What's your vision of what happens next, and what hospitals and organisations can do with this and other technology? Jackie?
Certainly for me, it's about how we get systems across the system really working or integrating from a digital perspective. And I feel at the moment patients coming in on pathways through ED, having sight of their sort of records from primary care and throughout into social care will be the thing that really will help revolutionise that experience for the patient, and ultimately then the experience that the staff are having. It's hard out there at the moment, and it feels very disjointed from that perspective. And certainly hearing this morning about how can we make a difference in bringing down those waiting lists, but really improving that patient experience. I think the digital infrastructure and transformational piece for me is definitely where we are in Worcestershire, that element that we just need to work to and join together. And so that may not be that it's the same EPR, but the infrastructure elements, so that things such as virtual wards, things such as outpatient appointments, people have, and particularly as a patient, they've got their ownership of it. So it's bringing that all together.
Thank you. Jane?
I think for me it's about giving our staff the time to think outside of the box and really use digital in an innovative way of changing care pathways. I think I heard today somebody talk about digital care module. They just don't get the time to think about what digital could actually do for them. We have roadmaps, we kind of prescribe to them exactly, virtual ward is the next new thing. But actually, is it really what your local population needs? Actually, as a challenge to me as a digital leader, I need to know what they would like to deliver, and it's my kind of remit to go away and see what I can do to facilitate that. Yes, there's a financial envelope that we need to look at, but it's about how I can support those clinicians to deliver better care that is sustainable for the future.
Thank you. I think very often clinicians appreciate kind of being led and directed through those first phases of an EPR programme, because not everybody can imagine working in a different way. But some way of cycling back round and being able to really take advantage of everything that they've learned, and once they've realised what's possible, then the other advantage, I guess, to still having the system that you can configure and that you can develop in a modular way is that you can go back round, can't you, and say, now you've been using this for a year, what are all the things you wish you'd told us, and how can we optimise and take advantage of what we've got. And I think I'd also echo Jackie's points that it's great, isn't it, that there are patient flow modules that Altera and other people sell that can really help to address flow in the hospital. But then we need to reach out, don't we, and work out how do you deal with flow across an ICS footprint. How do we engage the third sector? How do we engage adult social care, families, everybody? in the challenge of getting people out of a hospital bed and into a place that kind of best suits them, that's safest and best for them. We've not talked about it. I suspect it will come up in almost every other digital conference or session anyway, so I'll do it, which is the potential for AI. So the project at the front door at Gloucester, there's a bit of AI that can identify, just on the basis of information we've got already about them, if there's a patient who's likely to stay in the hospital for more than 21 days. We know that for every day that somebody over 70 spends in a hospital bed, they lose a year's worth of muscle mass and flexibility, and have life-changing loss of mobility if they get stuck in a hospital bed. So what can we do in the first 21 minutes or the first 21 hours that could help avoid those patients ending up in a hospital bed, keep them mobile, get them back home as soon as possible, and avoid that loss of mobility? And I think there's a whole ton of things that we can do that would really impact patients for the better and help to free up some of the challenges we've got around beds. So there's a roving microphone. If you're happy to ask a question or have a question you'd like to ask, if you could raise your hand. Chris wins that particular race, and we'll deal with that. Chris.
Right. Wow, this is extremely surreal, isn't it? I can empathise with the panel. Chris Fleming, I'm from Public Digital, so digital transformation consultancy. I'm really curious about the getting the right balance between bespoking and standardising with quite a customisable sort of arrangement. How did you find that balance? Do you think you got it right? And what governance? What was the effective governance around that to kind of manage it?
Go for it, Jen.
Yeah. Because we've been live for 2.5 years, I would say initially we didn't get it right. We went for a subject matter expert and asked them to tell us exactly how they felt that it should work. But subsequently what we've done is we've engaged much more about the clinicians in designing their whole clinical pathway before you've actually then introduced the digital solution to them. And that enables them to hopefully then have the conversations about how do we standardise our practice across maybe one organisation. We've got 2 sites, and even 2 sites can be very different. So we've now become a bit more mature as an EPR team, and we challenge back and say, well, when you're ready to tell us how you want your clinical pathway to look, then we can support that. Because otherwise we put a lot of effort and time into designing documents, flow sheets, pathways that they then go live with, and they go, I don't like this, I want to change it. So I think over time you kind of evolve that maturity, but also it is a slight responsibility, I think, of an EPR team to look outside and make sure that we are also reflecting best practice too. Coming to conferences like this or other kind of clinical conferences, you can help channel that at the same time.
I think one of the key elements of learning, certainly from a board level perspective, is getting the governance right around it. And I think that is evolving for us rather than it has evolved at the moment. And as it stands, it sits almost in 2 camps. And certainly making the transition from the role I was in to this role, actually the key learning for me is actually the governance for digital and changes, etc., is sitting here. And the patient safety element is sitting here. How can we bring the 2 together so actually the board and certainly our quality and safety committees, our non-executives are aware of what that is, because it feels like it sits 2 separately, yet it isn't, because one is impacting on the safety of the other. And that then goes back, as you were saying, to are we involving the right people in the bespoking nature? Because that is absolutely the right way to go, and I know certainly talking to some of our clinicians, that's the way they want it to go. I think in our journey, unlike yourself, we're still at a point where they don't know what they don't know at the moment. So they know they want it to look like this, and they want the ownership and the empowerment, and that's our vision, is for it to be very clinically designed and led. But at the moment, the digital is very much needed to take that leadership function. Our aim is to try and get that to shift.
I think there's a balance, isn't there? You know, I think starting with a blueprint, which is the best of what all the kind of Altera clients in the UK use, but then being able to tailor it to help your clinical teams is great. I think after that, exactly as you described, it's involving as many people as possible. The worst outcome is that you go live on a Monday and everybody in a clinical area is delighted, but then you get loads of requests for change on a Thursday, and it turns out that that's the member of the team who wasn't involved, and then they're not on shift the following Wednesday and everybody's happy again, and then they're upset on the Friday, and so involving everybody from the team, as with any change, is really important. Are there any other questions?
Thanks very much. Emmy Wynne-Jones, I'm a non-executive director at Doncaster Ambassador Foundation Trust, Acute Hospital Trust. It disappoints me, and this isn't the first time that I've heard it, that there's not been any proper, measurable, quantifiable benefits evaluation. To implement an EPR like this in an acute trust is an expensive and time-consuming and people-consuming exercise. As a non-executive member of a board, if there's any investment of public money being made, I would have thought that it was absolutely essential that right from the start there should be a process of benefits realisation and value for return for investment built into the process. And indeed, I'll put this over to the suppliers of the software and say that you ought to have, as part of your advice to the trust that's implementing, that there should be quantifiable, measurable benefits and disbenefits measurement built in. How can we stand up in front of the public and say we've spent so many hundreds of thousands of pounds of your money and we don't know what benefits we've realised? Yes, Dr. So-and-so thinks it's good, but apart from that, we've got nothing else. So just a plea, please, for more measurable, quantifiable benefit evaluation.
Yeah, well, I don't know if anybody's... go on, Jackie wants to speak. I've got a view, but I'll express it.
I think certainly one of the things that we've learned, and we've now got a role that's absolutely dedicated. So we're 6 months into our journey. And whilst it is there, so to be honest, there is a framework that's there that really looks at, I would say, as you say, quantifiable. I'd also like to add in, we need the qualitative elements to it as well. That's there. One of our learning is that we didn't put the investment in for having that workforce to capture that, because our clinical workforce at the moment is not able to do that. So actually, one of the things that we've put in and are working together much more now is to gather that data in much more real time, because as I said, feeding that back to a ward as well as the board is invaluable, because that's the celebration of success, driven by that value-based approach. And as you say, then we're capturing the value for money element. If I take, quality priorities, which, we report to the board on a very regular basis, we have seen, and we're now capturing it from a case study and then obviously onto the quantifiable elements, a real marked improvement in our pressure losses in the wards, because actually the staff have got the documentation, and they're being driven to do that from an accountability fashion, to document, and they can't go forward if they don't document it. So we are starting to see some of that going through, but I think it's bite-sized, and I really support that challenge from the board's perspective, that you need to keep driving this bit, not just from a financial point of view, but really importantly the patient outcome perspective.
I agree with all that, and we've got some really interesting stats from different sites, including releasing 25% of a nurse's time to care just as a result of taking the chaos and the telephone calls and the looking for paper out of the system. There's all sorts of stories of patients deteriorating overnight on one hospital site, which was observed at the other site by the acute care response team, because the electronic observations were being recorded, and the triggering was happening in a way that could never happen on paper. I guess the only thing I would say is, the organisation you're a non-exec of is a sort of size of a FTSE 250 company, none of which think it's right to work on paper anymore. And it's a bit like electricity. There were loads of things, I assume, that came out of electricity being everywhere. The person whose job it used to be to knock on the windows to wake people up was put out of business because the alarm clocks worked, and the person whose job it was to light the gas lights was put out of business, and people weren't falling over at night because the electric lights were all night. There's countless benefits from having electricity, and sometimes it's less about making the case up front and more about afterwards making sure that you've gathered up all those benefits as a way of explaining to a board that this is a continual investment. You need to continue to spend a decent proportion of your revenue and your capital to keep up to date and keep progressing, keep making care safer, keep making care more reliable. So I think a bit before, but loads after as well. Are there any other questions? Perfect, look at that, right on time. Thank you very much for your time. Thank you, Jane and Jackie, it's really very much appreciated.